Welcome to The Checkup. I'm Erica Teichert, Managing Editor of Modern Healthcare. In just a few months, the No Surprises Act will take effect. For patients, that will mean fewer concerns about surprise medical bills for out-of-network doctors or hospitals. For providers and payers, the Biden administration rule released on September 30th means ensuring patients don't receive balance bills either accidentally or intentionally, since the rule carries significant penalties. Communication between providers and payers must be constant to avoid any unlisted clinicians or services and to make sure all parties are informed whenever patients have agreed to pay for balance bills. But like most payment policies, the No Surprises Act also pits providers and payers against each other. Here to talk with us about how hospitals should prepare for implementation and what it means for future relations between industry heavyweights is Chip Kahn, President and CEO of the Federation of American Hospitals. Welcome to the Checkup, Chip.
Nice to see you today.
Thanks. How are you telling your membership to prepare for the No Surprises Act?
Well, since the beginning of this process, really almost 2 years, we have been very, very supportive of acting to protect patients. And we're working with our members now in terms of implementing this. They're looking forward to the opportunity to have the simplest, seamless process when patients who are out of network come to the hospital. And this act actually will help us with that, both in terms of the emergency room and their hospital payments, and also with those doctors that treat patients in the hospital who may not work for the hospital, but the patient's need for their services, whether it's anesthesiologists or pathologists or others, who now will have services that if they're out of network, the patient can be assured of a precise payment amount in terms of their cost sharing.
And some experts have said that the policy could increase premiums since the No Surprises Act is probably not going to prevent any settlements on unpaid bills at amounts higher than most insurers are paying for in-network care. I'm curious how you think the policy might impact premiums.
Well, there are really two parts to this process. One part is the patient part, and the other part is the payment for services part between the hospital or the physicians and a payer. It could be insurer or other third-party payer. And I think in terms of the patient part, the qualified payments that the insurance companies and other payers are going to come up with that the patient will pay some proportion of as their cost sharing, I think at the end of the day are likely to be considerably less than is being paid now by the insurers for those services out of network. And then when we take this other part where it's between us, the hospitals or the physicians and the payers, that the adjudication of those payments, I think now is going to lead probably to lower payments overall because the administration is heading in a direction with its regulation for a system in which this qualified payment that the insurance companies will develop has primacy. And so we have grave concerns about the implications of that, actually both for in-network and out-of-network activity. So if we think worst case here, and this immediate reg, which is an interim final, goes into effect at the beginning of the year, and the insurance companies and other payers can use this qualified payment in network, out of network, however they want, I think it will probably lead to some reduction in premiums because they're going to be paying less on the payer side.
Which wouldn't be too good for a lot of your members, I'm sure.
We think there needs to be a reasonable payment. There needs to be a reasonable payment that's worked out through negotiation, not some fabrication that the insurance companies develop. Yes, the qualified payments will be based on real data, but that whole process is going to be very opaque. The law, neither the law nor the regulation describes or provides for much transparency there. So we're not going to know exactly how they calculated the payments. As time goes on and new services get added, they're going to be able to, in a sense, develop the payments. So we're very, very concerned that the way the administration has chosen to carry out the implementation of this act will lead to depressed payments and not in a justifiable way.
Do you think the arbitration used for appealing these payments, is that going to be helpful in any way, or is there still more work that needs to be done?
The law is very clear that the arbitration needs to be independent. And we are very concerned that the way that the Labor Department, Treasury Department, and HHS have designed this regulation will lead to the insurer-payer qualified payment having primacy in that process, rather than, if we can't negotiate a price, having the ability to really present an arbiter a case and have the arbiter choose the price or a closer price to what the provider or the clinician serves up in the process. We're worried that process really cannot be independent the way that this reg is designed.
And let's go back to thinking about out-of-network and in-network care for a moment. I know that the industry has struggled to maintain accurate network directories for a long time, but it's something that is being addressed by some technology that's being adopted by payers. How can providers make sure that they're providing correct information to patients as well?
Well, and there are really two sides in this particular area to network. I would say my members generally want to be in network. They want to have that relationship with the patients that really is to the patient's advantage, and frankly makes that relationship more seamless in terms of the hospital serving the patients. Our problem has been here, and one of the things that led to this controversy is that we don't know at any given time whether all the physicians that are practicing in the hospital in these specialties, whether all of them are in or out of network. Sometimes that, in a sense, can change on a dime in terms of how they're dealing with the insurance companies. So it's been very difficult to keep track of that, and so I think it's really incumbent upon the insurers to make sure that their insureds have a clear understanding of who is and isn't out of network. Part of the issue here is that whether it's the emergency room physicians or the pathologists or the radiologists or the anesthesiologist, that generally those aren't physicians that a patient's chosen. A patient shows up at the emergency room. A patient chose an OBGYN for a birth or chose a surgeon for some procedure, chose the hospital, frequently because the hospital's in network for an elective, and then only sees the anesthesiologist when they walk in to ask for consent. And that's probably not the time that the patient wants to look the anesthesiologist in the eye and say, are you in network or not in network? So that's how we got here with the problem. And I think that the law will help us through that by giving the patient certainty whether they're in or out of network regarding their cost sharing.
And one of those issues, I'm sure, also could be outsourcing, and with the staffing shortages that are going on now, could those labor issues be affected by the No Surprises Act?
I think in terms of these the specialties, you have sort of two things going on with hospitals. In some cases, hospitals will have on staff the specialists that we're talking about, and on top of that, they may have a hospitalist on staff. In other cases, they have voluntary medical staff, and they may contract with a practice, but those physicians aren't employed by the hospital. I think the issue that's going to be a problem here in terms of access is that if the payers come in and try to manipulate this qualified payment and frankly lowball it, there will be, I think, a response on the physician side, and we may see some physicians decide not to practice in certain areas of the country or certain parts of the state because the rates in that area are so low, and that could cause access issues and cause us problems in trying to bring staff in.
And what are 3 things that you'd encourage providers to do to prepare for the No Surprises Act?
Well, I think we all want to be in network and maintain that if we possibly can. So that is sort of job 1 here. Second, I think the act on the patient side is going to be a big plus because now we just need to know from an insurer what the qualified payment is if someone's out of network. So I think that aspect of it should be a lot more seamless in an emergency room. In the other areas of the hospital, it'll be between the physician and the patient. But for us, in terms of our facilities, I think it's going to make things simpler. The issue for us is going to be on that back end, being able to contend through a negotiation process and then ultimately in whatever cases that need be are taken to a arbitration. That's going to be the more difficult part of it, but the patient's out of that.
Well, thank you so much for your time, Chip.
It was a pleasure being here today, and I hope this was helpful.
It was. Thank you.